Okay, this is a recording for Facet joint syndrome. This applies to both cervical and lumbar spine. And I'm going to spend a little bit of time talking about the difficult part of spine. Once you understand this, um, it's not bad, but and this doesn't specifically apply to facet joint syndrome, but I want to put in a little bit of the anatomy for the spine here and there. So here it is. This is a spine. This is a back view. This is a picture of the spine, just in case you don't have an orientation. This is a neck up here. This is the butt. This is a posterior view. So you're looking at from the back. It looks like a shovel. Okay, you've seen this in Predator, I know. That guy rips the spine out and just the whole thing comes out. Yeah, right. This is the front view, the shovel. This is called the lumbar segment, the thoracic segment or the mid-back, and then the cervical segment. They've got a separate name for the C1, which is called atlas, and C2, which is called the axis. If you look at this bone, there's a little bone that sticks up like this. That's called the odontoid. You can have various different fractures around this area, and it'll kill you instantly if you get the spinal cord. Brain stem is up here. And then the head is up here. This picture doesn't have it, but that's called the occiput for occipital area. But let me show you this, okay? There are nerves that come out of each level, okay? I mean, obviously the function of the spine is to give us flexibility. It's a wonderful structure. And then through the inside canal, there's a spinal cord. And the spinal cord actually ends in most patients, most people around T12 down to L1. And then it turns into just individual nerves, so strands of nerves called cauda, or the tail, equina, tail of a horse. You know how tail of a horse has got a lot of strands. And so you can actually pass a needle straight through all around this area and you won't cause much damage. I mean, you can stab those nerves. They just cause pain, but no big deal. Of course, you can't use too big of a needle. I passed needles straight through the canal all the way into the disc for what would be crazy things that we used to do. But if you pass a needle at the spinal cord level, then you will cause damage. And I've had the misfortune of doing that one time. The patient fortunately survived, but spinal cord, you can pass the needle through the spinal cord, but it'll cause some damage. They perform surgeries on spinal cord. Okay, so that's the spinal cord is inside the canal. And out of the spinal cord at each level, on the holes on the side, one on each side, comes the nerves, okay? So those are called selective nerves, okay? So they're one nerve at a time. So we're going to count the nerves just for fun, okay? Bear with me. And those of you who are doing reviews, you don't have to. You can skip through this section, but this is designed for my physician assistants and nurse practitioners. So C1 nerve comes out between the head and the C1. Okay, there's a hole up here. It's called the occiput. It's called C1 nerve. Starts from top between the occiput and the C1. Okay, I just got kicked out, so let's go back. C1 body, and then the second nerve comes out between C1 and C2. That makes sense, right? So C2 nerve between C1 and 2, because C1 comes out between occiput and the C1 vertebral body. Each one of the vertebral bodies over here are numbered individually, and the discs are numbered by the level above and level below. So this disc right here will be C7-T1 disc, and then the hole in between will be C7-T1 foramen or hole, okay? And so the nerves are individually named. So the nerve there's a nerve that comes out of each one of these holes, and that's the one that we're trying to number, because pretty soon you'll find out that it's very confusing for no reason, just because somebody just didn't number them with any reason. They just numbered it on their own. So C1 comes out of between occiput and C1 vertebral body, or the atlas. Okay, that makes sense. C2 from between C1 and 2, C3 between C2 and 3, all the way down to C7. Okay, what comes out between C7 and T1? They should have called this T1. Okay, instead they called it C8. And I had a dispute with one of the nurses, and he told me, I asked for a C8 selective nerve block when I first came out here in Sacramento, and she said, what are you talking about? There's no C8. She was correct, except she was thinking the vertebral body, there's no C8 level, C7 and then T11, but there is a C8 nerve between C7 and T1. We call it C8 nerve. Okay, and then what happens after that? After T1, between T1 and T2, out of this hole right here comes out T1 nerve root. And if you go all the way down, okay, T12, down between T12 and L1 is a T12 nerve. Okay, and then if you come all the way down here, L5, and this is S1, this is sacrum. That's all fused. The vertebral bodies are fused. That's why it looks like a shovel, but L5 nerve comes out from L5 and S1. Now, look at this one. S1 nerve just comes out of the S1 foramen. That's nice, right? So if had they numbered these foramen just with one number, just like down here, we wouldn't have any confusion. All right? So when you say L5-1 foramen, L5 nerve comes out. We should have just called it L5 foramen. Then we would have L5 nerve coming out of it. But look at the confusion. Look at L5 S1 is L5. Look up here, C7 T1. It should be C7, right? But it's C8. So the numbering in cervical spine versus thoracic and lumbar spine is different. And this is where the confusion is. Look at this. Between the C2 nerve comes out of C1-2, okay? The L1-2 is actually L1 nerve, not L2. Just look at this one. All right, this is confusing. C1-2 is C2. If we do L1-2, it's actually L2 nerve. I'm saying L1 nerve. Yeah, I got confused myself. All right, so just remember the relationship between the foramen and the nerve that comes out is different from cervical spine and thoracic and lumbar spine. Okay, thoracic and lumbar spine is same, but they're different from cervical spine. So I came up with a little rule. Cervical nerve root above the vertebral body. Okay, so if you're thinking C6 nerve, think of C6 vertebral body. It comes above that, so comes out of the hole above the C6, so it comes out of C5-6 foramen. For thoracic and lumbar spine, it actually comes below the vertebral body. So if you're thinking L5, where does L5 come out? It's below L5 vertebral body, so between L5 and S1. Okay, how about L4? Where does that come out of? It's below the L4 vertebral body, so it's L4-5. How about C7? Well, the cervical spine is above, so what's the level above C7? C6-7, right? So it comes out of C6-7. So a simple rule to remember: for cervical spine, the neck is above, the rest is below. Okay? Well, anyways, this can be really confusing because when we ask for injections and whatnot. But let's go to the facet joints. The facet joints have a couple of different names. One's a facet joint, facet face. Facet, it means that they face each other. Another word is zygopophyseal joint, but it's too complicated. So gladly, I'm sorry. Fortunately, that word is quickly fading out. I think they're just using that on the literature only. But the facet joints are what we call there's little joints in the back of the spine. So you see, this is the vertebral body, the anterior column. This is the belly button up here. This is the back, the spinous process that's coming out in the back. Okay, and so these are true joints. Those true tiny little joints that truly articulate between one vertebral level to the next vertebral level. Look at this one. This one connects to this one by this facet joint in the back, as well as the disc. Obviously, the integrity of this segment is mostly by the disc, okay? But if you put a shear force, anterior posterior shear force, then you see a lot of force taken up by the facet joints. All right, so they do play a role in providing us with. And this is another picture looking at from a little bit of an angle. They put little red marks on the facet joints. Those are the tiny little joints, one on each side. And remember, facet joints cause lateralized pain. Patients can have either pain in the midline of the spine. Those are never facet joints. And if you see reports that say patients have midline or central low back pain, and if they ask for facet joints on both sides, then that's a bogus request. And for any patient that has centralized midline pain, a facet joint is not to be asked for. So they cause lateralized pain, okay, what we call paravertebral tenderness next to the vertebral column. Para means next to. So simply because the facet joints are located over the right, off to the side. You know, every joint in our body can cause pain. You know, arthritis of the fingers, they cause finger pain. Arthritis of the knee cause knee pain. But you know what's interesting? Facet joints, they can look normal and still cause pain. I'll explain that later. And spine is quirky. It's in a different universe. Okay, so they're not like the hip joints or the knee joints or shoulder joints. You can have a lot of arthritis in these facet joints on MRI X-rays and still have no pain. They can look completely normal and still cause pain. But in the lumbar spine, they're more closely related to how they look on the X-rays and MRIs. In other words, there's a little more correlation, but in the cervical spine, there's less correlation between how they look and what the patients actually experience. So let's get a closer look. This is just a spinal segment. You see the spinous process coming out, the transverse process off to the side, the handles. You see the disc. So we're looking at from the back to the front. These are little joints on the back of the spine. So you can imagine the spinal canal. This is a hole, a contiguous hole, or the spinal canal just behind what we call a lamina. This is a lamina. So when they do laminectomy, they cut this portion. A hemilaminectomy is half of it. Okay. Posterior decompression, it's also called. It's like taking the roof off. Facetectomy is when they cut this whole facet joint out to really open things up in the spinal canal. So you've got a spinal canal here, and then you got vertebral body in the front. But these are facet joints in the back of the spine. Okay, and then look at this one. This is just the picture of the cervical spine. Cervical spine is similar, but you can see that the spinous process is longer. They look a little bit different. They have these little conduits where the nerves come out, and these are called oncovertebral joints, but these are not true joints. They just look like it. But they do have facet joints. The alignment of the facet joints are different in the cervical spine than the lumbar spine. These are more flat, laying down. These are more standing up, but that's not important. Okay, so let's go to the next page. Here's a picture of what's supposed to be a facet joint injection, okay, where you can treat the facet joints various different methods. We'll talk about that. One, you can just put a needle right into the joint, just like, you know, doctors stick a needle into the hip joint or knee joint to treat arthritis, right? So we can do the same thing with the facet joints, put a needle right into the joint. But I will tell you that this is not my picture, because whoever put this up on the internet didn't know what the heck they're doing. Okay, because this is not intra-articular. This is what you call a muscle injection, but they still outline the facet joints. That's why I put it up here. Okay, if you put a needle in the facet joint, you can. This is the any radio tech, X-ray tech will look at this and say, that looks kind of suspicious. I think this one may have gotten some into the joint because you'll see this little blob of contrast coming up here, but this one is they completely missed it. And you see this from time to time. A lot of these guys have done these injections without proper training, and they just, these are tiny joints. They're not easy to get into. So they just put something around it, and if it looks something like that, it covers a facet joint, they pull it out and say, hey, that's a facet injection. But anyways, we can put a needle into the facet joints, but they don't work, okay? The ODG guidelines allow facet joint, intra-articular joint injection only as a diagnostic purpose, not for therapeutic purposes. We now know that if you put a needle in the facet joints for therapeutic purposes to treat the facet joint mediated pain, it doesn't work. It just ends up confusing us because there's such a high placebo response. Placebo means getting better just because a doctor put a needle in your back. Okay, it fools the brain, and the brain latches on to this belief that something was done for the pain, and the brain transiently will suppress that pain and gives you a false reading. That's what placebo response is. But anyways, so it really confused us for a long time, but we now know that intra-articular facet joint injections do not work. So only time that you do facet injection is for diagnostic purposes, and we're doing less and less of that. Okay, so if they ask for intra-articular facet injection, if they don't say diagnostic purposes, do not authorize them, or we certainly would not ask for that. Okay, I stopped doing the intra-articular facet injections. I wish they worked, because this is a pretty nifty injection. They're fun to get into. Once you get in, they don't look like this. But anyways, here's a picture of the cervical facet joint injection. I used to do quite a number of these until guidelines came out, and they're not all that beneficial. Cervical facet joint injections are more difficult to get in than the lumbar spine, and you can imagine how many doctors are just kind of played around with it, calling it facet injection. But fortunately, we don't have to do those anymore. So how do you evaluate cervical or facet joint syndrome? Okay, so you got to look at this very carefully, because I'm going to be talking about the medial branch blocks. Okay, it's also called dorsal medial branch blocks. All right, dorsal medial. So here's a spine, lumbar spine. You can see the sacrum over here. I'm sorry, sacrum down here. This is the pelvis. Okay, this is the L5, and this is the S, sacrum level. Here's a needle, small needle right at the neck. This needle is positioned a little bit high for the dorsal medial branch is usually found right around here. Okay, but anyways, this picture shows the needle at the neck of what we call the pedicle. This is a pedicle. This is the transverse process. So this is a neck between the transverse process and the pedicle. If you put a needle right there, you will hit this dorsal medial branch nerve. Okay, and I'm going to draw it out for you. Let's start with this picture over here. All right, you've got the main nerve, the nerve root. Okay, so if I'm looking at, this is L4 and this is L5, between L4 and L5, which nerve would come out? The lumbar spine is below, so L4 nerve would come out of here, between L4 and 5. So let me put a picture here. So the L4 nerve is coming out here, down like this. That's this L4 nerve. And then That's called the L4 nerve root. That's the main nerve, so I drew it to pretty thick. And then you have this dorsal medial, okay? It's dorsal because it's behind. There's an anterior branch also that goes up front, but there's the dorsal, and then among the dorsal, you got the medial branch that goes out medially, and there's a lateral branch that goes out and then innervates the something else. Okay, so we don't care about. I don't know what that innervates, but this is a dorsal medial branch. Okay, and the dorsal medial branch comes out of the main nerve like this. You can look at it over here, and then it splits. It goes into this facet joint, and the same nerve, a branch of it, goes down the facet joint below. Okay, so this is the part of the anatomy that's confusing. That's why I'm explaining it to you. But let me put some numbers up. This is L4, L5. Okay, this one is the dorsal medial branch of the L4, but this one supplies to facet joints. Okay. So if I want to treat this one facet joint, I not only have to block this one, which goes in this, but I have to block the one above, because there's another one that comes out, the L3, comes out, sends out a dorsal medial branch that sends it down below and at the level, right? So every dorsal medial branch supply 2 facet joints, which means that to get one facet joint, you have to burn 2 nerves. But we often treat 2 facet joints at a time, and that's what ODG guidelines recommend, and that's what we're going to do. And so to get 2 facet joints, because of the overlap, you have to get 3 dorsal medial branch blocks. So the most common facet joints that are involved in the lumbar spine are the bottom 2, because these are the ones that bear most of the weight. The L4-5 facet joint over here, and then L5-1 facet. Actually, L5-1 facet joint is down here, and then L4-5 facet joint over here. So to get these 2 facet joints, I have to burn or get L3-4-5 dorsal medial branch. So I can go through all that the anatomy, but that's kind of confusing. But just remember, 3 for 2. Many doctors don't know this unless you specialize in this. And then unfortunately, we ask for 3-level dorsal medial branches, and I've seen once in a while the reviewers will deny and say you're asking for too many, because the ODG guidelines only recommend 2 levels, and that doctor doesn't know. It means that they don't know what the heck they're talking about. Because when we ask for 3 dorsal medial branch blocks, it covers 2 facet joints. Okay, so 3 for 2 rule. All right, so anatomy is always confusing, but I had to go through that. What do the guidelines say about facet joint evaluations and treatments? Let's look at the ACOM really quick. Under cervical spine, page 174, it says there is limited evidence that RF neurotomy may be effective. There's limited evidence, but that means that some evidence, the radiofrequency neurotomy. There are 3 different ways you can say the radiofrequency ablation. All right, that's just the way it is, and you have to pick them out. One is facet rhizotomy. Rhizo means the root. Otomy means to cut. So you're cutting the facet, the nerve root. Okay, so that's dorsal medial branch, referring to dorsal medial branch. Okay, so you're cutting it. That's more general terminology. Or in other words, radio frequency ablation. Ablate means to sever, okay, cut. And then radio frequency neurotomy. Neurotomy means to cut the nerve, right? So they mean the same thing. ACOM guidelines, page 300, lumbar spine. It says lumbar facet neurotomies reportedly produce mixed results. Facet neurotomies should be performed only after appropriate investigation involving controlled differential dorsal medial branch diagnostic blocks. I missed a little spelling there. What do they mean by controlled differential dorsal medial branch blocks? Forget about it. You don't have to know. The guidelines changed. This book came out 2007, and since then it's been updated. They only recommend 1 diagnostic block now. Okay, so you don't have to do controlled differential. I mean, You don't have to do multiple diagnostics. I used to do that 5 years ago, but no more. All right, so let's go into a little more discussion. This is for lumbar spine, ODG guidelines. Facet joint pain, okay, there's a criteria for that. First thing is you got to have tenderness to palpation in the paravertebral area, which means that they have to have lateralized pain, and then they have to have normal sensory examination and absence of radicular findings, although pain may radiate below the knee. So the pain has to be primarily in the low back, not much pain down the leg. And then they have to have palpatory tenderness in the paravertebral area over the facet joints, which means that anybody who has chronic back pain, they're going to have, you touch them, they're going to have pain. But this is one of it just means that they have to have lateralized pain, okay? And then normal straight leg raising exam. The reason for this is that if they have positive straight leg raise exam, it means that they have radiculopathy, and the radiculopathy would explain the back pain. And since the facet joint mediated pain is much less common, they don't want you to look at the facet joint if the patient has radiculopathy. Okay, that's the reasoning behind that. Criteria for diagnostic blocks for facet mediated pain. So they're telling you this is how you should be doing a diagnostic block. Okay. Number one, only one set of diagnostics, and they have to have greater or equal to 70% reduction of pain and 2 hours for lidocaine. For bupivacaine, it's a longer-acting local anesthetic. It can be 4 to 6 hours. But they need to have relief for at least 2 hours for about 70% greater than 70% reduction of pain. It has to be non-radicular, 2 levels bilaterally. This is referring to 2 facet joint levels. And you know what, ODG guidelines, because of the confusion, they actually explain this, okay, which I thought was kind of interesting. It says blocking, remember what I said, blocking L4-5 and 5S1 will require blocks of L3, 4, 5 with the option of blocking the S1. So if you get a request for 3, 4, 5, and S1, we do have to authorize it because the ODG guidelines allow for that. It looks like 4 levels, but it actually covers these 2. Getting the L3, 4, 5 should be sufficient. And for my office, for lumbar facet joint diagnostic evaluation, I don't ask for anything else other than 3, 4, 5 for 95 plus percentage of the time. There are situations when they have mid-lumbar pain and some rare exceptions where they have more arthritis in the mid-lumbar area. Then I can go up to the above levels, but I don't do more than 3 dorsal medial branch blocks to cover 2 facet joints because that's what the guidelines allow for. IV sedation is only allowed for Facet unless extreme anxiety. Doctors can't use propofol or fentanyl, which are pain IV medications, because it kind of negates the pain response, right? If the surgery is anticipated in that area, then you can't do diagnostic. And if they had fusion at that level, then facet diagnostic evaluation is not allowed. Okay, criteria for facet joint RF neurotomy. They have to have a diagnosis of facet joint pain as above. Repeat neurotomies are the criteria, no more than 3 times a year. That's a little bit excessive. And then duration of relief has to be 50% for at least 12 weeks. That's a little bit short, but anyways, that's what they have in the guidelines. And again, no more than 2 levels. For the cervical spine, it's identical, okay? And they just have one more description. Symptoms, the most common symptom is unilateral pain that does not radiate past the shoulder. Remember, lateralized pain, okay? So when do we look at the facet joints? Here's another picture of the facet joints. You got a dorsal medial branch that supplies the facet joint at that level and then sends the branch down to the level below, okay, remember? So it's very simple, okay? First, they have to have lateralized pain. And number 2, not much leg pain. And normal sensory and negative straight leg raise. That's it. Okay? All right? The patient, and then the question might arise, what about x-ray findings, MRI findings, bone scans, extension maneuvers? None of these matter. Okay? This is only 3 things you have to have. Just lateralized pain, not much leg pain, and radiographic findings don't matter. I mean, most physicians, you have no idea how many times I've fought with these utilization review doctors. explaining to them X-rays, MRIs don't matter. They say the MRI didn't show much. This, oh please. Anyways, those are the guys that don't read the guidelines, and which is not good. So for diagnostics, L345 has to be greater than 70% relief and no sedation. And guess what? That's it. And the cervical spine is the same thing. And that's the end of Facet joint syndrome for education. I got that through in 30 minutes, which is awesome. All right. Thank you. And that's it.